Our third speaker and our first speaker during the last part of our session is Meng Chong. Meng Chong is a counseling psychologist at the infectious disease unit of UMMC, Malaysia, with strong interest in HIV and mental health. As the very first psychologist working in her unit, she works closely with clinicians, nurses, and established the first infectious disease wellness clinic in Malaysia, which includes mental health care for people living with HIV. And she was one of the fellow. You were. Oh yes,
I was.
okay.
I'm still
She
part of it,
was.
I
She
would like to
was.
think.
She was one of the fellow under NH Fund Capacity, the Chimera program, which is the implementation science research in HIV and mental health training program, and currently enrolled into the PhD program at University of Malaya with project focuses on mental health implementation in the infectious disease clinics. So please join me and welcome Meng Chong.
Thank you. So, a disclaimer, I'll be talking about mental health a lot more tomorrow at the plenary. But I'll touch base a little bit on mental health during this talk because they are so related to each other, substance use and mental health, yeah? So this is the topics I'm going to cover. I'm going to start with substance use 101 and mental health 101. Then I'm going to explore on the association of substance use, mental health, and HIV. The third topic will be substance use screening and treatment. Lastly, I'm going to give some recommendation for screening and treatment. So substance use refers to the use of any substance. It can be a controlled medication or illegal drug, cannabis, tobacco, nicotine, and alcohol. And we know people use this substance for various reasons, including medical purposes, personal enjoyment, religious or ceremonial purposes, or to cope with stress, trauma, or pain in life. And I would like to introduce this concept of continuum of substance use. Substance use occurs along a spectrum, yeah, ranging from no use at all to experiencing a substance use disorder. So what I'm trying to say here is that not all substance use is problematic, yeah? Substance use can be beneficial if used under medical supervision. And we should bear in mind that most of the individual are non-problematic user where there are no physical or mental health impact from their substance usage. A small proportion of the user would have become problematic use if their patterns or types of usage cause some extent of physical and mental health impact. If nothing is being done to this problematic usage, it might progress into a more harmful usage and eventually it reach a point where it becomes a substance use disorder. And what about mental health? It's a state of mental well-being that enables people to first connect with other people, being able to empathize with another human being, to build positive relationship, to get a sense of belonging in life. It also helps us understand and manage our emotion, both positive and negative emotions, such as stress. It helps us to adapt to changes in life throughout our life course and adopting new ideas in life. It helps us to learn, it helps us to work better and make more informed choices in life. It's like a Lego that help us to gel everything together in life for us to live a fulfilling life. Just like the continuum of substance use, mental health is not a binary state where it is a yes or no. It exists on a complex continuum as well, with experiencing ranging from an optimal state, excelling, to the worst, where they are in so much pain in life, emotional pain or suffering. So mental health is not defined by the presence or absence of a mental disorder. Along the different dimension of the mental health continuum, mental health issue and challenges present in a different way to each individual, meaning to say, even though you and I go through life stressor, the same life stressor at the same time point in our life, we go through it very differently, we experience symptoms very differently, and the event itself affects us differently as well. And of course, we all gonna have a different clinical outcome based on what we experience. Depression and anxiety, for example, can manifest in a very short period of mild, moderate distress that lasts for maybe few hours, just like what I'm standing here presenting. I feel distressed, yeah? So, but this is just a short-term distress. But it can also be manifest in a long-term, more severe condition where it lasts for months or years. So some of the commonly used substance for people living with substance use disorder include alcohol, tobacco, opioid, stimulants, marijuana, hallucinogen, or prescribed drugs. And some of the most common mental health disorder include anxiety and mood disorder, depression, PTSD, bipolar, schizophrenia, conduct disorder, ADHD. And what I'm trying to introduce here is a co-occurring disorder where we have one or more substance use disorder that coexist with mental health disorder. So it is quite common that's happening, and so it is a combination of two conditions, and we have to bear in mind that there is no specific combination. For example, someone could have an alcohol addiction issue and PTSD. So that is what we call a co-occurring disorder. It can be a combination of any of the two from each category. And people with mental health illness are at higher risk of developing substance use disorder compared to those without mental illness. Similarly, individuals with substance use disorder are particularly vulnerable to developing mental health condition. And mental health disorder including history of trauma, someone who has PTSD, that may drive or exacerbate the individual substance usage. And similarly, ongoing use of substance can put the individual at a higher risk of trauma, for example, a sexual assault or a sexual exploitation, which may further increase their substance usage. So it is very, very important to routinely screen someone with substance use disorder for mental health condition and vice versa for early detection, which makes management a little bit easier. And substance use is related. Substance use and mental health is related to HIV in the following way. The use of alcohol or some recreational drug can lead to increased risk-taking behavior that increase the chances of getting HIV or passing it to others. People under the influence of substance are more likely to have poorer adherence to any treatment or healthcare. There will be poorer engagement with the healthcare system. And the use of recreational drug and alcohol can weaken the immune body and affects the organ as well. For people at risk of HIV, substance use and mental health issue does not just reduce the adherence among PrEP user. It affects how the brain function, including your memory, your attention, and the way that you reason. So it impairs a clear thinking and increases the likelihood of poor decision and makes PrEP on demand, event-driven PrEP, a little bit more challenging. So some risky behavior can increase the risk of getting or transmitting HIV. For example, people who use drug or alcohol may have sex without condom or even share needle if they are injecting drugs. So in addition to the effect on people at risk of HIV, for people living with HIV, substance use and mental health issues are more likely to affect their HIV treatment outcome, treatment adherence, which lead to a poorer HIV treatment outcome. Other than the impact cognitive dysfunction due to substance, potential drug and drug interaction has been mentioned in so many times today. So that is something that are more likely to happen as well for substance user. So this slide shows some of the consideration on the selection of HIV treatment for people with substance use disorder. We would prefer a once-a-day pill in view of the potential challenges to adhere to twice-a-day formulary. And before starting on HIV medication, if the person living with substance use disorder are on treatment, potential drug-drug interaction should be verified first. And due to the possibility of non-adherence, we would prefer the option with a high barriers to resistance. Having said that, ongoing substance use is not a contraindication for prescribing HIV medication. HIV medication is recommended for all people with HIV to improve their health and to prevent transmission of HIV to other people through condolences sex or sharing needles. This clinical, community, and individual level benefit should encourage healthcare provider to initiate HART in all people with HIV who use a substance. Harm reduction services, for example, motivational interview or needle exchange program should also be offered as part of the integrated care services. For people actively injecting drug, engagement in a needle exchange program can be a regular point of contact for them, especially those with a complex health and social challenges. It provides a lot of opportunity to offer other services to support their life. So as a reminder, I want to emphasize that not all substance users are problematic users. Having said that, I'm just trying to look at the data that we have. How often are we screening for substance use disorder? In a study that was done on 95 HIV treatment centers from the IDEAL site, there's 28% of them are not screening for substance use at all. And over here, I'm telling you that there are tons of screening tools that we have, and there's only 10 here. If I were to go down the list, I'm gonna be digging the rabbit hole. There are so many of them, which I think give us the next questions. Since there are so many screening tools, which one is the best? Which one is the shortest? Can it be patient administered or it has to be interview? Does it apply? Is it available in your own local languages? All this consideration has to be thought of before you using a tool. And the message here is there is no one perfect tool for everybody. You have to find a tool that suits your population. So I have done, through my Chimera program, I have done qualitative interview with my clients, people living with HIV, attending the UMC clinic in Malaysia. And I asked them, what makes substance use screening and treatment challenging? Number one, the user themselves they see that if I can still go to work, I can still go on with my life, there's no problem. I do not need treatment, so why do you screen me? And some of the patients actually say, substance use issue is something that I will get over it myself. When it's time, it will recover. Just like your flu, your fever, it will recover itself. I do not need treatment. And in Malaysia, I think in like many of your country of origin, substance use is a criminal act. So most of them are so afraid of telling the provider about their substance use because they might face a legal consequences. But the positive side, what would help the screening and treatment for substance use? Although substance use is a criminal act, using substance is a criminal act in my country, they say that if the healthcare provider communicate clearly with me that why are they screening me for substance use, and it is for my benefit that you are screening me, they are okay. They feel that they are happy to be screened for substance use. And they also felt that mental health training for HIV healthcare provider is so important because HIV healthcare provider are mostly trained for HIV and ID, but not mental health. So they want mental health training to be done on the provider before we start screening. And because substance use is such a stigmatized and I would say a private issue, they would want a designated space for mental health care in the ID clinic itself. And in our clinic, because I think like most of the clinic, they have to go to a registration counter and then there will be a waiting area, then they see the doctor, then links to pharmacy. They want the registration for mental health service and HIV service to be done in the same registration process where they do not have to go to multiple places, multiple times to do registration and repeat the same process again. So some of the recommendation for screening and treatment, and I would say is really from what I know so far. Number one, because just now I mentioned, substance use disorder and mental health disorder, they are so prevalent together as a co-occurring disorder. A trans-diagnostic approach is so important because it recognizes that most individuals do not present with a single issue and it often multiple problems co-occur. So this strategy can potentially impact individuals with mixed symptoms can be deployed and they can be linked to interventions such as community outreach activity to enhance their wellness, to give education, to provide support, or even brief intervention for psychological intervention. And this can be delivered by a non-specialized healthcare provider. And task shifting means training a non-specialized healthcare provider with no or little prior training in substance use and mental health to deliver the services, including low-intensity psychological treatment, like what I say, brief intervention. And this may include the paramedics, the counter staff, your nurses, community health workers, or even lay health provider like the peer supporter. This approach in delivering mental health care has been shown to be effective and cost-effective, though the majority of the evidence comes from the general population and fewer comes from people living with HIV. A step care model in which task shifting may be deployed include where you have a non-specialized staff maybe doing the screening, and then a low-intensive intervention given by your nurse. And then if they need more intense intervention, then they get referred to a more trained specialist. So finally, we need to be, I think, more innovative in simplifying the process that we have in place. I think most of us work in the healthcare system where it's already built from the dinosaur years. So how are we using innovative way, online, offline, to simplify the processes that we have in place for screening, delivery of treatment, facilitating the training for non-specialized provider to enhance the care coordination across different levels of healthcare system. So with that, I end my presentation. Thank you for your attention.
Thank you, Meng. So very broad and interesting, comprehensive look at substance use, but also mental health. So we do have time for a couple of questions from the floor, and maybe perhaps whilst someone comes up to the microphone to pose those questions, I could take the opportunity to ask you something. And you know, you correctly sort of highlight the fact that you know, often it's not a single substance that is used by a particular person. Often substance uses are co-occurring with mental health disorders, and I think to a large extent that's the norm rather than the exception. And in relation to that, so it would seem that trans-diagnostic approaches to screening, trans-diagnostic approaches to treatment is a no-brainer. So my question is, well, why are these not more prevalent? Why do we not routinely always use transdiagnostic screening tools? Why do we not implement interventions that have impact across multiple mental health and or substance use disorder conditions? So perhaps you could talk a little bit about that and your kind of perspective from the work you do in your clinic. Thank you.
So let's start. I'm going back to the screening tool. Some of the older screening tool, and I would say the screening tool that maybe is more towards the assessment tool, that's more specific to a single substance. For example, alcohol screening and brief intervention for youth. So this is one screening tool for one condition. So from my personal experience, if I would to screen for 8 substances, meaning to say I have to find 8 instruments to screen for substance use, right? But think about the last time you had to do a survey, you were eagerly trying to finish off that survey, isn't it? It just felt too long. So what screening tool that I like was actually Assist in the middle here, because it is very adaptive to any drug. It is a very flexible tool that allows people to add in whatever drug that they are using, and then you can assess for that using one single tool. And to answer your questions, why are we not doing more than just 1 or 2 conditions? I think we are too afraid to start, I feel. We scientists always want evidence-based intervention, and we need a paper to tell us this can be combined with this so that it works. We need that kind of evidence to direct us in the next journey. And I felt that was at least as a provider, I think that's my biggest holdback myself in trying to do more, to combine tools, to be more innovative, I think.
Okay, thank you very much, Meng Lee. Okay, since there are no questions from the floor yet, I may have want to ask one more, very similar to what Jeremy just asked in terms of the screening tools. So perhaps maybe you can tell us a bit on what it is currently being done in UMC, perhaps in terms of the decision on which types, which screening tool you use, and maybe a little bit on how you came to the conclusion that this is the screening tool that you were going to use.
I think we started off with something similar as like Audit C, like to test one item, and then we slowly want to answer to add in more tool. But I realized it's just too lengthy, and then now we are actually using Assist as the mean to screen for substance use. And just to give you a snapshot, because I will be presenting on this tomorrow at the plenary session on mental health, we are actually using a tool that is transdiagnostic, that's developed by Columbia University. So we are testing that tool out, and it's as part of the implementation science research. And from that, we learned so much. What is the process that we should put in place to improve things? I think the bottom line is that we provider has to be flexible and has that dynamic mindset that there is no perfect tool. There is a perfect tool for now, but this can change over time depending on the demand and the situation and the population that we are serving. So it's plenary talk tomorrow on mental health.
Okay, and perhaps I've got time for a quick follow-up question. So you mentioned that you use Assist, and Assist is a kind of substance use screening tool. And for any particular substance that you screen for using Assist, you're given a score, like a specific substance involvement score. And my understanding is that if you have a score of greater than 3, this is except alcohol, then that's some sort of indication of moderate to high-risk behaviors or a requirement for further assessment or interventions. Now, I've not done a cyst on myself, but I might well have a substance, involvement score of certain substances, tobacco or alcohol, that puts me in risk categories. And I'm just wondering, because, in some of your earlier data, you mentioned the kind of, as barriers to screening, the fact that people don't perceive themselves as being at risk or having a problem. So when you screen someone and they have an assist score of 3, do they say, oh, well, that's, and then you talk to them about interventions and the need to do something? Are they like, well, no, I don't have an issue, or I don't have a problem?
Yep, very, very great questions. And I'm actually doing a study on this, trying to understand why people don't return back after screening, although referral was being made. I think, yes, ASSIST give you a risk score that they're going to put them in the 3 different category of risk level. And as a psychologist, I felt that that tool is only a way that I use to start the conversation with my client. And maybe by the end of the day, we can't just work on the item, the substance that has the highest score. It doesn't work that way, because we know polydrug is so common in the community. So it's really a personalized intervention that has to be catered for that individual. And just following up on that different category substance, right? I noticed, and from the screen that we have done in the clinic using ASSIST, people with regardless of what substance was flagged as high risk, it is all back to that individual, whether they are motivated to change, whether that sees the benefit of change. So it brings us back to the basic human communication. Is it important for you? What's in it for you? Is to have that conversation. I hope I answered your questions.
Thank you, Meng. So we're going to move on to the last of our 4 presenters before the panel discussion. So please, Dr. Rainer Tan, please go to the podium. Dr. Rainer is an assistant professor at the So Sui Hock School of Public Health, the National University of Singapore and National University Health System, where he received his PhD. He currently is the president of Project X Society, serving the health and social needs of sex workers